Dr. Heniford, welcome to the Cutting Edge. I'm so excited to have this conversation. I've been waiting weeks for the opportunity to finally meet you. As I said, I'm almost a fanboy. I've been in the world of hernia. I worked with Dr. Franz up in Michigan when I was a fellow. I did some research. I have a couple patents in the field, but really in the field of hernia, you are one of the greats. So much is downstream of your work. I think you still influence hernia in not just nationally, but internationally, and that's going to probably stay that way for decades to come. But here we are at SAGES. What were you talking about at SAGES in your session, and what do you think are the big key talking points that have come out of that session?
Well, the session that they had me run was was about getting out of trouble, and I think that like any type of major operation, there are decision points, and we started a session by talking about like how not to get into trouble in the first place, and then there are break points with different types of operations, and that's what we discussed. And one of the cool talks was David Chen. I actually asked him to talk about taking care of VIPs, like really important people, whether they would be your colleagues, professional athletes, people who are like movie stars and stuff, because that's what he does. But he gave a great talk about treating humans like humans. It was fantastic.
So what came out of that part of the conversation? Basically that there's still just people? Is that?
That's right. You don't really want to change what you do for patients just because of who they are, and you also have to work with the nursing staff, other surgeons, people in the operating room to treat them like normal people. Yeah, you treat people special. You treat special people special. They develop special complications, and there's also the security of their privacy. Yeah, securing that.
In terms of SAGES itself, I'm sure you've been here for many years, and where do you see SAGES in the field of hernia, and what makes them different than the other hernia societies?
Well, I think SAGES has a broad scope, and SAGES is the the American College of Surgeons used to be the biggest meeting. Was it just a tremendous meeting representing general surgery? And I'll tell you, like SAGES has really kind of pushed up into that, and the contemporary surgeon I think identifies with SAGES very well as compared to other groups. Yeah, so SAGES, minimally invasive surgery, that push into minimally invasive surgery and helping perform guidelines, helping young surgeons actually find jobs. I mean, there's so much that SAGES does, yeah.
And I really want to kind of take a turn here, and you've been, as I said, a master hernia surgeon for decades. When you look back at the history of hernia since your start till now, what does that look like from your perspective? How do you see the transition and the techniques that are used? Where have you seen the big fails that have occurred and the big victories that have come out of the last 30 years?
Yeah, so I think that the biggest thing about hernia repair is people taking it seriously. It used to be if you said you're a hernia surgeon, you're a little bit shunned. You're not really a surgeon. And the most common operations performed in the world, if you look at our recurrence rates, instance of hurting someone's quality of life, infection, these operations are real. The patients are much more complicated than people would give them credit for, and they're more comorbid. For ventral hernias, people are in your office for a reason. They often have separated themselves from the herd as far as their ability to heal, tendency to develop an infection, and those sorts of things. And so first and foremost is like people taking it seriously. The next thing is understanding the complexity. And I think too, we've allowed ourselves to be honest. One of the first meetings I went to about hernia, the American Hernia Society, someone stood up at the front, and it's true, and said, 400 cases, like 2 mild wound infections, no recurrences, and everybody's lovely. And I'm sitting in the back, and I said, we should stop everything that we're doing going forward, because that's perfection. Don't do any type of ventral hernia any other way than that. But we knew that wasn't authentic, So, but if you look at over time, the number of complications are going up, the number of recurrences are going up, and you say, well, we're getting better, we understand this, actually we're becoming more honest. And so by becoming more honest, you give yourself an honest report card, then you can change. And I think the ability for us to say we could do better has allowed us to do better. That has been the biggest change. And then the other consideration is you get expert surgeons in this world. You get the Conrad Bowsers, the David Chens, Mike Rosen, Yuri Novitsky, Igor Belyansky's. I mean, people who ring the bell in the world. They would have been a really good surgeon doing anything else. But these guys chose to do hernias. And so they've made this a very legitimate profession. And then, and again, I can just keep going about this because there's been so much change. But now we have young people, like we'll have 140 people apply for one fellowship position. And I think that young people now, because we've applied science to it, We know that the technical aspects of this, that these are not easy operations. People are now respecting the surgeons and the operations themselves. And if you give, you give young people approachable heroes in a complex operations, where they can actually separate themselves as a real specialist. And even you can become board certified through the European Board of Surgery in abdominal wall surgery.
Really?
And so, yeah, but and then the family type effect of just those people that I just named, and how they are open and warm and approachable to young people, and it's made young people want to do it.
No, absolutely, I hear you. And I think that a question I've always said about hernia, I really want to kind of dive into this a little bit. It was American Hernia Society conference, this was probably 10, 15 years ago, and somebody said, it might have been Bruce Ramshaw, but all abdominal wall catastrophes start with an umbilical hernia repair. And a hand went up and he said, hey, what's the best way to do an umbilical hernia? And nobody could really answer that question.
Right.
And do you think that does play some role in the fact that there's so much diversity in how we do these things? Is there a specific procedure we should be striving for, or is that really the answer? Is it the procedure itself, or is there something else?
I talk to people now and they'll be like, oh, if it's an umbilical hernia, it's more than 2 centimeters, I'm doing it robotically. And I'm like, that's not the way a lot of people would approach that. And so, and a lot of people get themselves kind of locked into one particular procedure, or one particular technique, or one particular type of instrument like the robot. And I will say to that one option is no option.
Yep.
Now, the first thing is that you evaluate the patient, and it's about what the patient wants. We are quality of life surgeons. It is really uncommon now that I save lives. But what I am is I try to be the best quality of life surgeon I possibly can. And to try and fit a patient into what I believe I do well is probably the wrong approach. You have to talk to the patient, describe the various operations, describe the strength of those operations, and then the possible outcomes, and let the patient help you decide.
It does seem like abdominal wall in particular, there's so many variables. And you're talking from instrumentation, from products that you're using, from which planes you're going to be in. Obviously, any of those planes are a viable option. I always tell a story. I was met with Dr. Schuldeis once, and we talked for a few hours, and I said, how come nobody can reproduce your data? And he said, well, here's why. They come up there and I teach them, and then they go back and they do it their way. They modify it, and I said, I never really thought of it from that perspective. Is it because of the modifications and the fact that how are we supposed to, should we be trying to standardize these procedures? Is it even possible to try to standardize these procedures?
I think we should standardize them as much as we can. There's standardization, and then there would be, kind of the optimal non-standard approaches. And so I guess it's optimal variability. How about that?
Right.
Standardization versus optimal variability. And there's also, one of the things you have to really think about is the difference between efficacy and efficiency. Efficacy of something, we do a big study and people are younger than 18 are out of it, people older than 65 are out of it, weight, smoking, diabetes, so you get this set of patients you can operate on, and here are the outcomes. But then efficiency is 2 o'clock in the morning, and it's a 65-year-old with a BMI of 47, and then what do you do for that patient? And so when I talk to my fellows, knowing the literature, knowing what your skill set is, and then applying that the best that you can, but also knowing the literature. But a lot of the literature is weak, very fragile data. So you always have to just do your best. Know those things about yourself, know those things about the patient, know those things about the literature, and do your best.
And I experienced this once too. I was around a round table, and we probably had a dozen surgeons, hernia surgeon specialists from all around the world. And they gave us 9 scenarios, and we came up with 15 different outcomes. Everybody had a different solution to it. And you looked at we can't even agree. And everybody there pretty much knew the data. General knowledge of the data. And still we couldn't agree because, as you said, the data is not necessarily horribly strong in all these areas. And there's so many variables to try and account for. But also, I think where you're trained, who you're trained under, what you're comfortable with, because you can really make some big errors in the abdominal wall if you don't know what you're doing. But what does that algorithm look like to you? When you look at a patient, how do you work through that?
Well, having done this for a long time, I'd like to think I can fix the abdominal wall really any way it can be fixed. But there's so many variables. It's going to be about their comorbidity. It's going to be about their previous surgery. Do they have mesh? What plane is the mesh in? What are their, some of these patients will have really PTSD from having had previous surgeries and failures, and now you're in your office for another one. But the most important thing is bringing in what the patient's concerns are, what the patient wants, what their expected outcomes are. And sometimes you got to bring those back down to earth a bit, what their expected outcomes are. But, education of the patient, let the patient educate you, and then you can apply what you believe to be best for what they have.
Dr. Roth, Scott Roth, is a very big fan of saying, maybe we're picking the wrong outcomes. We've been so focused on recurrences. Is that really, if you have a 1 centimeter recurrence on a massive abdominal reconstruction, is that really a failure? And one, we know that over time, the body's changing. You're going to have some, it's like a knee replacement. So are we going to have to be looking at this again in 10 years? And two, do we need to go back and be operating on these small failures? Are they really a failure? What are your thoughts on all that?
Yeah, you do your best to not have a recurrence. The most complicated hernia is the one that's either infected or recurrent. And then every time you operate on someone who's recurrent, you increase the chance of complications, and then you increase the chance of recurrences. And so I don't like the thought of, well, it's like a knee replacement, it's good for 15 years, and then you're going to have to cycle that knee out. But we're going back inside someone's abdomen. And so you got a chance of fistula, you got a chance of significant infection, and so I'd like to try and fix them. And Scott may be right, but I don't like the thought of that, honestly. But if you get a small recurrence after a big hernia repair, and the patient's well, often you leave that patient alone, and you would call it a win. But the problem with that is that we don't measure quality of life very well, and we try. But even when patients come in and they're worried about MASH and they're worried about their complications and what their outcomes can be, even patients who've had failures and had difficult quality of life or problematic quality of life now, they won't return their surveys. Oh. And so you talk to the patients like, you're going to make me a better surgeon, and then you get a 13% return of surveys, and then what happened to the 87%? So you really can't make authoritative, even decisions going forward, or to say how well you've done.
Yeah, and I think that's actually what Dr. Ross is saying too. Quality of life really seems to be a better outcome measure.
Right, yeah. But then you can't measure it because people won't return their surveys.
Yeah, I never really thought you're right. It's difficult. Plus, the follow-ups, I mean, how long do you typically want to follow up on your patients? Every year? Or?
Well, it becomes more and more difficult the more and more patients you operate on. And then in our service, we operate about 70% of the people we operate on from out of state. So we lean on the family practice doctors for a lot of that. A lot of the follow-up, and a lot of the follow-up physical exams and those sorts of things. I like to follow them as long as possible, but indeed, it's just like anything. It's hard to get, how often do you return a survey when someone says, how did you like this product on Amazon?
Yeah.
It's a little different than surgery, of course, but still.
But I think even then you're going to have some bias. I mean, the people that are really angry about it, they're going to send you something.
Correct.
And the ones that are really happy about it, they're like, oh, it's good. So you might not get that same response from them.
Yep, you don't know who's responding, why they're responding, their biases with their response.
So you see the worst of the worst. Obviously, you've done some of the hardest hernias out there. Are there any absolute no's for you?
I think that, and so it's interesting that AHS, they asked me to give that talk. And one of the things that I said in that talk is, as a general surgeon in the community, please don't say no until they've gotten a second opinion. Because often I'll see people in the office who, got a big hernia, multi-time recurrent hernia, going to have to excise skin, take care of a fistula, and people say they're not, you can't take care of those people. Before I would do that, I would have them see someone that you might call an expert, just to get a second opinion of no forever in those people, first and foremost. The hard no's are people that, if I'm going to put their life at risk, and we see those patients very frequently, they come in and they're like, I have to get this fixed. The quality of life is not that bad. They just don't like the way it looks, but you're going to put their life at risk. People who are fairly comorbid, especially with heart disease, lung disease, and those sorts of things. The other hard no, so we started working with geriatrics in our clinic. And so if you're geriatric patients, increased risk of complications, increased risk of going to the ICU, increased risk of failure, and at our place, increased length of stay. We documented that as one of the 6 things that increases length of stay, looking at 2,500 patients. And so immediately with this, you say, well, you can't fix age. Well, we brought geriatrics in their clinic. So on Mondays, Mary Devane, who is a geriatrician, sitting in clinic with me, and she's seeing these patients. And then a hard no for me has now expanded. She is so good. The hard no for me has now expanded. Is like, these patients, you don't recognize that they're struggling mentally. And then she'll say, they have a 78% chance of not going home, looking at their data. And all of a sudden, I'm like, I can't operate on that person. Yeah. And then also their family and the patient's like, oh, no, I don't want any more surgery. So she backs, like a hard no. The answer is a hard no with that, which I never considered before. I mean, you got other hard no's about, people who are smoking, extensively smoking, morbidly obese, very uncontrolled diabetes, those are hard no's for me, unless they're truly symptomatic. And they're very symptomatic, then maybe we have to do something about it.
Imagine a platform that connects you directly to a private group of surgical colleagues. Within the app, you interact socially with colleagues, post your own surgical videos, scan the library for relevant content by type of surgical procedure, anatomy, or even specific operative step. You'll be invited to live webinars and build your network through conferences hosted on the app, all while maintaining your privacy. SurgeOn, where surgeons go to explore, discover, and learn.
And I'm going to change subject a little bit because I want to go back to, for a long time, TAR was the gold standard. We go to hernia conferences and you'd see the experts.
It's so crazy that you say TAR is a gold standard when, Yuri first wrote about that in 2012.
But that's what I'm saying. For those like decade there, you go to these conferences, and the general population hernia surgeon that was out there at these conferences is saying, like, I feel obligated. I got to learn this because it's this amazing new procedure. And now I think we're seeing the long-term effect of some of those not going quite as planned. And I'm not here to attack anybody in this situation. It's more of a, how do we manage something when you're looking at the solution is a relatively complex surgery that really does require some extra training, but at the same time, it seems to be the solution to a lot of these patients' problems, and these other surgeons don't want to feel left behind and that they can't do something. So how do you fix that divide?
So, I think there's some interesting ways to do that. Doing preceptorships, we allow, but people will come in and spend 2 weeks with us, and they'll just look over our shoulder for 2 weeks. I hope if I'm moving to Chicago, I hope when I move to Chicago, we'll actually have people be able to come in and scrub in as well to get a great look at what we do. And I'll share that with anyone. The problem with transverse abdominal release, again, it's just a hernia, first and foremost. You see these beautiful videos, like Igor Belinsky puts these incredible, unicorn videos up, and that guy can go in the OR. He was an amazing fellow and is an incredible surgeon. The problem is they look so good. Yeah. So you get a beautiful operation that looks like no bleeding, it's a beautiful procedure, you just cut through this layer of muscle, and people think they could and should do that, and I can do that. And unfortunately, they end up cutting through the nerves, devascularizing, and also denervating the rectus muscle, cutting through the semilunaris. It becomes a huge problem. But Yuri did a survey of 275 people in the American Hernia Society. 65% of those people said, "Yeah, I can do TAR, and I can learn it in less than 10 procedures." 25% of them said they do TAR, and they learned it online. I learned it by YouTube.
Yeah.
I'll tell you, that's a little bothersome.
And I will say, there's something to be said about to get that, to see more of it, but you have to still get the training. The hands-on training definitely is key to understanding the anatomy, to understanding these. But I also want to talk about that. If you cut through similar nerves, I had this patient show up, the bilateral, the
Mickey Mouse hernia.
Exactly, the Mickey Mouse hernia. What's the way to fix those now? It seems like because those planes have been disrupted. When you see those, what do you think?
So the last one, I saw a patient just last week in clinic. Mickey Mouse hernias, the rectus muscles are still intact.
Yeah.
The small piece of mesh that they put in the rectus is still intact, but the rectus muscles now are flat and they don't work. First thing to do is, and I talked to patients, let's be honest with them. I don't know how this happened, but indeed, your rectus muscles are not going to work. Can we fix these hernias? The answer is, there's a really good chance we can fix those hernias. In a patient like that, I will go through a midline incision, I'll elevate the skin and subcutaneous tissues, put their abdominal wall back together, do a pre-peritoneal mesh most often, because often they've had just a rectal rectus repair. I'll do a big pre-peritoneal mesh in those patients. But you have to be, authentic and realistic about how their abdomen's going to work after that, because the rectus muscles are essentially dead. They don't work anymore. The other consideration is if those defects are pretty big, Botox. You want to Botox or lateral abdominal wall, and could you do an external oblique release now to get this closed? I want to preserve as much muscle as possible. The transversalis muscles cut, rectus muscles don't work. To cut the external oblique, now the only muscle they have intact is their internal, which is not one of the strongest muscles in your abdominal wall. So I will do anything I can to keep the external obliques intact, and I'll Botox those patients. Consider pneumoperitoneum in those patients as well.
And we've been using Botox. I love it. It works amazing. Insurance companies don't always buy into it, though.
Yeah.
Have you noticed any tricks to get it through the insurance companies?
Yeah. So one of the things that, Ava Derenberg from Holland, she was our fellow, and she spent some real time digging into this for us, with us, and published 3 nice papers on this. But we demonstrated we can decrease the number of component separations that we would do, and also increase the patients in whom we could get their fascia closed. And I emphasize to the insurance companies, the Botox, our radiologists do it. They do a great job. They've been working with us for over 20 years. The cost of that, it's off-label, and there's cost of that. But if I have to do an external oblique release, one, I increase the chance of complications and wound complications, which at our institution is about $36,000 for a wound infection, wound complication.
Wow. Yeah.
And so that'll pay for it. Plus also, if I can eliminate a component separation, you don't have to pay me for that. And so that easily pays for the Botox. And so, so the combination of those two, and that we've actually published, now actually include the literature. And often you'll talk to someone who's like, wow, I never knew that, from the insurance company, I never knew this existed. This sounds like a great idea. We'll let you do it. But I often have to speak to people in the insurance company. 22% of the people I operate on now have Botox.
Really? 22%?
Yeah.
So you've been able to incorporate it into a significant portion of your practice?
Yeah, it's just because of the type of patients that I see.
Yeah.
Yeah.
I hate to focus too much on, let's say, devices or meshes, because I think that there's a debate that always to be had. But I do want to ask you about, what are your thoughts on long-term absorbers versus the non-absorbables at this point?
Yeah, so and I think that we really don't know the long-term outcomes of this. I think PhaseX came out in 2013. It was actually launched by Bard in 2013. It had been around for a few years before that under a different name. And it really has picked up steam. But you're getting people like John Fisher and Scott Roth and Guy Veller and some people who are actually gathering up some meaningful data with PhaseX. But also there's Inform by W.L. Gore, formerly BioA, now Inform. They've got some pretty good data. I'll just say, I do worry about absorbable meshes. If you look at lightweight polypropylene mesh, not typically used in the ventral abdomen. I was a big fan of lightweight polypropylene mesh when we first studied it. Once you get to 18 to 20 months, it starts to oxidize, becomes crystalline, will fracture, and you get recurrences because the mesh fractures. What happens when the absorbable meshes go away?
Yeah.
So if we want to decide not to use a lightweight mesh, which is plenty strong to begin with, and go to a midweight or a heavier weight mesh, and then you say, oh, but I'll use an absorbable, it makes me worry a little bit about what's going to happen long term. But there are patient groups that I think it will work well.
Yeah, I got to say, I've been back in on some of the PhaseX cases. It looks like it's still there. If you ever go back in 3-4 years out, but you can tell that scar tissue does have a tendency. You can see where it wants to crack. If you have too much motion, that can potentially tear that scar tissue, and that is also my fear. But at the same time, not having especially a large piece of permanent mesh in there, what's the trade-off? Is it worth?
Yeah, it's talk to the patient. The Gore meshes, and they do seem to leave a collagen barrier. They become like a collagen barrier, which has been demonstrated many times in reoperative patients and been looked at microscopically. So there is something left behind with that, but it takes long-term data. It really does.
Yeah. And now, as you look into the future of hernia, so you've had the last 30 years or so, and now you look in the future. Where do you see hernia going? Where do you see technology being integrated into, maybe AI going into it? Is there some place for that? What's your vision?
Well, I think it will be a specialty. I don't know that we'll ever have a card, like a colorectal surgeon or a vascular surgeon. We really need to be able to train, the best operations are performed at home. Rural general surgeons need to do a great hernia repair. But specialty centers for the really big defects, the complicated defects, and patients with a high chance of developing complications, they need to go to a specialty center. Yeah. But we have to train our general surgeons in the community to do a great hernia repair, great ventral hernia repair, great inguinal hernia repair. They need to have more than one option, and that's up to us to do that. But I think specialty, it's going to become a specialty. I think it's already recognized by the European Board of Surgery as its own specialty. And I think that you're going to see more and more young kids that will, I shouldn't say young kids, young surgeons. I'm old, but you'll see more and more young surgeons that are going to go into this. And I think almost every major academic institution, they're going to have hernia specialists. Yeah. People who can put the abdominal wall back together again. I don't think there's any question about that. And I also think that, we're not done with polypropylene. I think polypropylene, what have we used for the last, for more than 60 years in any surgery? Yeah. There's nothing. And so actually almost 70 years. And so I think we'll see other meshes coming out that will have better scientific data before they're launched by the FDA, so we don't have this mesh issue again. But I think we're not done with meshes yet.
I do think it's amazing. You're absolutely correct, obviously, because if we can stop the recurrences, if we can have really good early hernia prevention at the beginning, you don't have these abdominal catastrophes. You're not going to have to fix these massive problems, and you stop the cycle from even starting. That does seem to be the most important part of this.
Yeah.
How do you teach? This goes back to the question of the Hernia Society. How do I fix an umbilical hernia?
Yeah, I mean, again, I'll show my own bias, but someone who's got a relatively small defect, 2 or 3 centimeters, if it's above 1.5 centimeters, I'll almost always use mesh. There is some data now that if it's a centimeter or greater, that using mesh improves outcomes. Data from Holland, Rebecca did that data, and so, but like I'm just going to make a small incision and do a preperitoneal dissection and put the mesh in, and say out of the peritoneal cavity in the lion's share of those patients. So a small umbilical hernia, and like I'm much more likely to use mesh if they have a diastasis, if they have a recurrent hernia and those sorts of things as well, depending on, regardless of the size. But yeah, I'm an old guy, but it's hard to beat an incision, 25-minute operation. And I'm not going to blame someone or give anybody a hard time who wants to go in robotically to do that. Yeah. But, I'll keep it very localized. How about that?
Where do you see the robot changing this?
I think, I do some robotic surgery, and our fellows have to do robotic surgery. They have to know how to do it. I think that right now it's a master-slave deal. What you do is what the robot does, but in the future the robot will be able to help you. It'll make you a better surgeon, and it's going to be a bit like the computers on planes now. They can really really helps fly the plane, and so our guys have to prepare for that. And it won't be in my career. It'll certainly be in our fellows' career. So they all have to do the robot. I think it's laparoscopy versus robotic surgery, being able to tuck the mesh, outside the abdominal cavity, maybe a good thing. Yeah.
No, I agree with that. It's if you go back to when automated cars were discussed, they said we're going to slowly add features that'll start allowing you to feel that you're not in total control, but people don't want to just give up the control. I think force feedback's the first step of that. The DV5 and the force feedback, the safety of that, but it's the first thing to say, okay, too much, stop. And it's that lane departure system from your car when they first added it.
I think it's a great way to describe it.
Yeah, and so it's that first step in the process. I think you're absolutely right. It's going to be doing.
A good friend of mine is one of the trainers for a major airline, and he said, you know how you fly these great, amazing new planes, right? He goes, it takes a pilot and a dog. And I was like, well, what's the dog for? Of course, he baited me to bite the pilot in case he touches anything. But the pilots are there if there is an emergency, if there's a problem. So their training, their simulation training is all about wind shear and horrible problems. So they're ready to take over. It's going to be how you teach surgeons that are going to train for the next 30 years. I was thinking 30. Can you imagine what it's going to be like 30 years from now with AI and robotics? You're going to have to take care of the emergencies, but simulation is going to become, I believe, it's going to become incredibly important. Cadaver labs and functional cadaver labs where you perfuse cadavers, I think are going to be really important for surgeons.
Oh no, it's scary. We were at MBT January down in Houston, and they were saying that the first automated robotic, like the robot taught itself how to suture and suture. Now it wasn't on a human, but it was on. Right. But the fact is, we're there. I mean, it's starting. Sure. They're starting to do it already.
Yeah.
And I've heard anywhere from 5 years to 20 years, and somewhere in that system, like some of that time frame, the system is going to change.
It's going to happen. Yeah. I mean, we just need to get out in front of this. So when I was at Creighton in Phoenix, and they have an amazing cadaver lab, perfused cadavers, and they put their residents in situations where there's a bleeding, injured iliac artery, which is actually bleeding in front of you, and they get control and they suture it. Can you imagine how much better they will be after doing that 2 or 3 times in the cadaver lab, and then have a trauma where the same thing happens?
Yeah.
So as robotics comes on, and then you have to convert to open because there's a complication, because there's a problem, things like that are going to be important.
No, absolutely, absolutely. Is there anything else you'd like to finish with? Is there any talking about the thing that you've learned all the years? I always say wisdom versus knowledge. Like knowledge is the stuff you read in the books. Wisdom is the thing that you learned simply because you had to experience it. Where would you see your wisdom?
It's we went from, when I was a second-year resident, all the inguinal hernias were done by a second-year resident, or interns rather. All the second-year resident cases, all the ventral hernias were second-year resident cases. And then, then when I was a 5th year, I was supposed to teach people, and I didn't do any in my 3rd and 4th year. And so, like that treating a hernia as if it was a secondary procedure is now no longer there. People are taking it seriously, and it's been a great ride.